Good evening, everybody. Today will be the second wave of NCD Academy regarding the COVID-19 regional panel discussion about managing chronic disease alongside the COVID-19. That's views from Middle East and Africa. The first was 1 month ago, but I have with me at that time three distinguished experts from different regions of the Middle East. And today I have with me two distinguished expert participants, Dr. Professor Habib Gamra and Professor Oyere Onuma. If you allow me, the coronavirus pandemics, as you all know, unfolds, and we have all grown accustomed to the latest case and mortality counts as a regular in feature programming. So these figures are imperfect and likely underestimate the number of infected, even less understood is the number of individuals without COVID-19 who have suffered indirectly from disruption, acute care, and services to manage chronic disease. For this instrument of the NCD Academy and the panel discussion, I'm pleased to be speaking with experts from around the region about those patients, these undocumented victims of the COVID-19, not the COVID-19 patients, but undocumented victims, and what steps we can take at the healthcare providers to ensure their needs are not overlooked. My name is Mohamed Sobhy. I'm a professor of cardiology at Alexandria University and the past president of Egyptian Society of Cardiology and chairman of the CBREP Foundation. I'm Middle East representative, Assembly of International Governor ECC, and Save a Life Ambassador, and also chairman of YC Hospital Alexandria. I have with me Professor Habib Gamra, Professor Oyere Onuma. Can you, Habib, introduce yourself, please?
Yes, thank you, Mohammed. It's my pleasure to be with you tonight. My name is Habib Gamra. Hello, you hear me?
Yes, yes.
My name is Habib Gamra. I'm professor of cardiology, head of cardiology department in Fatouma Bourguiba University Hospital in Monastir, Tunisia. I'm the past president of the African Heart Network and the current president of the Tunisian Heart Foundation. And very pleased to be with you tonight to talk about this terrible pandemic and its impact on the disruption of care in the African continent.
Dr. Oyere Onuma, introduce yourself.
Yeah. Yes, Mohamed, thank you very much. My name is Oyere Onuma. I'm an assistant professor of cardiology at the Yale University School of Medicine. I'm also an affiliate faculty at the Yale Institute of Global Health. I've worked quite closely with colleagues in the Pan-African Society of Cardiology, as well as the Nigerian Cardiac Society. So I'm pretty pleased to be a part of this panel. Thank you.
So you are working in the World Heart Organization?
I had previously worked at the World Health Organization in their cardiovascular disease management unit prior to coming to Yale.
So this is great for discussion because you have an expert in the World Heart Organization. If you allow me, I have a lot of questions on the topics today, but I want to be sure that we don't leave any general updates regarding COVID and its importance. To begin with, we have, before discussion, I can give you, both of you, and can go for a change with you as well. If this group was aware of any ongoing trials, you hear about this, or recent publications out of our region or in our regions that have light on potential therapies on the behavior of the novel coronavirus? Start with Habib.
I'm not aware of any trial actually that was published in a good journal. For Tunisia, for example, there was a special supplement dedicated to COVID in the country, but it was just about some kind of epidemiology data or a few cases. You know that Tunisia actually was not very heavily touched by the epidemic in the beginning, and we have just few cases. And by the way, there was a number of studies that were initiated in the beginning, then they were stopped because the virus has almost gone until the country has opened its borders on June 27. And since that time, we're seeing now a dramatic rise of the pandemic with big numbers, and it looks with the second wave that is even worse than the first one. And then all those ideas, they're back now, and investigators are recruiting patients, particularly the impact of hydroxychloroquine and antiviral agents, and they're trying to recruit few patients. Now, this is regarding Tunisia and Africa. There is something that is ongoing in Pasteur Institute in Tunis, which is the development of a vaccine that is manufactured in the country. Now, there are a few things happening in South Africa, but again, I'm not aware of any published manuscript. The only thing that I have seen from South Africa is an editorial that was published a month ago from our colleagues at the Journal of South Africa Medicine. I think it's called like South Africa Journal of Medicine, where actually there was few data about the pandemic, but there is no results of any trial. So, to me, there is no published trial with results that will be really useful.
Okay. So concentrating on the vaccine and epidemiology in
basically, yes, but also on the impact of particular.
Yeah, so I think for me, the most exciting thing that's happened in the region recently actually is not directly about COVID, but the news about the eradication or elimination of the wild poliovirus from the African continent, I think is fantastic news, not only because we need some good news in the middle of the pandemic, but also I think it's an important reminder that if we have a concerted and collective public health effort and strategy, that it can bring about tremendous change. Also, a lot of the infrastructure, including the personnel and technology and everything that was built for polio eradication, can probably be repurposed for COVID, especially when a vaccine becomes available and needs to be rolled out, in the community. So I think, it's an exciting development, might not be directly about COVID, but I think there may be aspects of that issue that are widely applicable.
Okay. For me, I look to that, those outside our region, we have, I found that two recent trials, but it's called solitary clinical trials in WHO serological testing. This one important trial done by the WHO. The second is published in the Lancet about the new drug approval. This is only the two which affects the coronavirus. About my country, Egypt, we have already 50 publications in the Middle East, 22 of them are from Egypt. And these 22 concentrated mainly on epidemiology and the hotspots and on using different drugs, even the drugs for virus C, which already succeeded in eradication of the virus C. Nowadays, in the protocol, this combination of two antivirals, and also about the convalescent plasma, and recently about the vaccine, this pilot study with China in Egypt. So this has come inside, maybe in the drugs, maybe something be in the futures used for machine learning or data mining for what's happening in our country. As Habib said, yes, it's not the second wave. I think it is the ignorance or the reluctance of the country that already the COVID is diminished. That's why everybody is no social distance or difficult to make social distance, no mask. The cases increased in the last week in Egypt because the beaches for the feast. So it's not actually called the second wave. It's the same virus, but maybe that we are rather reluctant. So that's why I come to our questions after that regarding how to do it. Then come to the finishing this. You come to an important. Anything you can add here about this? Okay. About the coronavirus dependent service for the NCD patient at all levels, it's important that we distinguish between disruption to acute care on one hand, and on routine and planned care to prevent and manage disease on the other, because they are such difference. The question is, looking first at acute disease, hospitals have seen an alarming drop. All of us saw that this alarming drop on the admission of the patient of emergencies, acute particularly acute myocardial infarction, acute coronary syndrome, acute heart failure, acute pulmonary edema, for example. Are those trends for the acute cases are reversing nowadays in Habib?
Yes. First of all, Mohamed, I just would like to mention something about the trials that are published outside of our region. There was a meta-analysis that was published on August 12 regarding the effect of hydroxychloroquine with 23 trials, I think, included. And it has almost concluded that there is no benefit of the drug. So this is probably would help actually how to manage the patients in the coming weeks and months. Now, regarding your question and what was the impact actually of the COVID pandemic on the number of patients admitted, etc. I can tell you for about 6 weeks, the department was almost shut down. So there was no acute patients, particularly STEMI, acute coronary syndrome patients. They have dropped dramatically. And now, since time, gradually, I would say, but quite abruptly, we have a very high number of patients coming back to the hospital. It's like they were hiding their symptoms for some time, and they were sometimes. Then when the doors were open, they came back very in a big number. So now we're at the normal speed, I would say. The usual number even higher than before.
So it's reversing, yeah.
Yes.
No.
And I would absolutely concur with that, to say that, a lot of the changes are dependent on exactly where you are sort of in the pandemic. So initially, with the initial kind of, shutdowns and the initial wave of infections, we certainly saw a significant drop off, not just in the numbers from the outpatients, but, in admissions. And I think, Habib, just going to your point, there was a couple of different things kind of playing into that. One was just the, shutdown from the service standpoint of, kind of non-essential procedures. But the other part of it is, also from the patient standpoint. Patients are nervous about, coming to the hospital. We're very nervous about exposure to COVID. Healthcare workers were nervous. But I will say that, especially in places that are now in the sort of post-pandemic, where numbers are under control, if not completely eliminated, that we've definitely seen a significant rebound in that number, as well as sort of the phenomenon of patients presenting, quite late with myocardial infarctions or strokes or completed infarctions that occurred, during the period when they weren't actively seeking care.
In the COVID era, astonishing enough, there is no drop of STEMI patients or acute heart failure. I don't know why. Even in the Stent Save a Life, I just have 1 month ago and 1.5 months in the PCR seminar with them, that already the number increased. So I don't know that the Egyptian doesn't afraid to come to the hospital because of the STEMI. The ambulance was working well, and the doctors are keen because already we have a lot of PPE in our hospitals. But actually, the chronic cases was markedly decreased by more than 75%. The elective cases or the chronic cases, but nothing changed in the acute cases. So because of a good triage and because of but nowadays still we have a triage, but now the patients are not afraid to go to the hospital. So the chronic cases come by themselves. Even the clinics, they come to the clinics. In my clinic already the number increased, because they don't, already we have a social distance and we have disinfection and we have everything for the mask, but now increasing the number coming back, even in the hospital coming back, even in the governments, they open the elective cases, as Habib said, the governments went back. So we have to live with this new life after COVID. So it will stay with us and we have to make it. But regarding the drop, I don't think it doesn't affect. So the question number 2, I'll start with Habib. I will start with Oyere. Okay, the lady first. I'm sorry to say. Has your institution modified acute cardiac care or how you admit and treat patients with acute complication from other forms of chronic disease to protect against COVID? Me. Okay.
Yes, I think we definitely
Go
have.
ahead.
I want to sort of make a point that is related to the other question that we
I
were
can't
talking.
hear you. Can
Oh, I was just saying, can you hear me now? Hello?
Yes, I can hear you.
Okay. I was just saying I wanted to make a point related
yes.
to some of the stuff we were talking about before, which is to say that
Hello.
the response in any country is probably related to the level of COVID infection that they're dealing with. So in countries where there was just, maybe sporadic infections or cluster infections, the response is quite different than countries where you have widespread, community infection, and that kind of has had an effect on the level of disruption of services and how comfortable patients feel with coming to the hospital. In terms of, my own experience or our own experience in terms of acute services, I think something that we leaned very heavily on in the initial, phases was really kind of putting in place, like you were mentioning earlier, a very robust triage system. Like, being able to really look at patients and, triage as to whether or not they were in need of urgent care, or whether these were cases that we could perhaps, defer for a short while, or whether these were sort of non-urgent, non-emergent cases, and sort of approaching acute care that way. I think because there are so many unknowns and so many things that we didn't know at that time, being able to protect, healthcare workers and, in that setting was primary. And so we sort of leaned into a triage system, which as, time has gone on and, we've learned more and the case numbers for COVID, are much reduced. We're using a lot less of that triage system for acute care. But I would say at the height of COVID, and this was for us in, March and April to mid-May, that was one of the key approaches towards acute care.
So, Habib, what happened in Tunis?
Yeah, I mean, again, allow me, Mohammed, to call it first wave and second wave, even if it's the same virus, but it's exactly the story. For the first wave, we are really prepared for the worst. So we have a crisis cell that was meeting a daily meeting to prepare for the worst. And you know that the pandemic has hit the African continent a little bit late compared to Europe and the USA. So we had some time actually to prepare ourselves and to try to copy what has been done in Europe and the USA a little bit, and try to work on triage, but also on separation of buildings, COVID building, no COVID building. So we were really prepared to that. And by the way, we have 2 ICU, one surgical, one medical. We said the surgical ICU would take care of all the acute care patients, and the medical ICU would be dedicated for COVID patients. And then all the rest of the patients, the stable ones, they would be infected, they would be hospitalized in the infectious disease department, which is in a separate building. And then if that department is completely full, then we move to the cardiology department, etc. Nothing of that happened because we did not have a high number of patients. In 3 months, we have only 1,000, almost 1,000 contaminated individuals. We can go back to there and the reliability of those figures, etc., the number of tested patients, etc. But that was the reality. That was the number of affected individuals. So nothing happened with that. And then we came back in May and June. We came back to work normally, okay? And then we have been hit very lately with the second wave. And to be honest, we're not doing the same thing that we have done in the first wave. Though now we're working almost normally. It's like a normal life, living with the virus and not very much afraid of the virus as we used to be in March and April, where everybody was confined at home, the complete lockdown, etc. So this is what's happening now. We're living with the virus. We're trying, of course, to wear mask, wash hands, etc., etc. But my feeling is that people and the medical community too, they're not much afraid of the virus as they used to be in the first wave.
I agree completely with what you said, that even it depends on the country itself and the number of the COVIDs. Like started in Italy, China, Spain, London. They make a designated hospital for those for even emergencies. But we are lucky for the Middle East and Africa, we don't have this, and we learn it from them. So we have time to prepare ourselves, although we are low or middle income countries, we are not like them. So our the cath lab are not prepared to be like even the United States, they make the negative pressure of cath lab changing. Maybe they make it for filterizations, but we don't have this. Still, we don't have all of this. But actually, we take time to make triage, infection control, and we learn. We have everyday meetings or every week meeting for all departments, and then we find a solution. The triage is important, decreasing the elective at the beginning till the curve flattened, and now come back. But we took in Egypt what's mentioned in the American College of Cardiology, SCI, at about the levels of 0, 1, 2. I mean that level 0 do regular services in some hospitals, regular 1 most services, regular 2 some services. This is depending upon the quality of each hospital itself, not doing everything in any hospitals. So we are not triage for these hospitals according to the circulation, because as Habib said, how to go to the ICU, because it's not just to postpone the patient, how to circulate the patient to go to the ICU. If you have a STEMI patient with COVID, you have to do the patient then make a CT or doing a test and then send it to the isolation and so on. So this is how to learn now, but depending on the metric measure of the quality of each hospital, they should have the level of services, 0 American College. That's what's happening now in Egypt after the first, as you said, first wave or the first part of the COVID, which we learned a lot, and now we come back to live with the new life of COVID. This will transfer us to a third question, maybe more or less the same, about the modifying or delaying of the treatment of face-to-face visits with the providers. For example, if you use an oral therapy over chemotherapy for cancer patients, they have to do chemotherapy, but because you don't have face-to-face, you have them oral therapy, send them the drugs. So in the field of cardiology in your countries, have you seen any unfold in this practical or particular field, and what lessons are we learning from this adjustment? How can you change this in country? Oyere?
So I think yes.
Oyere, can you answer these questions about do you have any change?
Yes. So I was just going to say that, there have been, as we've all talked about, the significant disruptions, even in, outpatient and inpatient care, and, needing to do things differently. I think what has happened, in our setting is that, there was a significant pivot. So I think that, in terms of even some of the treatments that we were able to offer, you just mentioned earlier, the acute STEMI patients, coming in. At the height of COVID, we were actually, per guidelines, doing thrombolysis in acute STEMI patients with COVID, as opposed to going to the cath lab for an intervention, just based on, sort of the exposures that you would expect, with COVID in the, for imaging in the cath lab, in the ICUs. So that to me is sort of, one concrete example of, changing our treatment patterns and, treatment guidelines based on for acute and inpatient care for COVID patients. Something else we did a lot of, instead of doing sort of, full scale echocardiography like we typically would do with acute ICU patients, it was a lot of, handheld echocardiography, again, to avoid the full exposure for treating those COVID patients. So I think that there's definitely been some modifications in the treatment pathway for these patients in the setting of the pandemic.
Habib.
Yes.
Habib.
Yeah, Mohammed. I mean, there was a change, of course. Thrombolysis, as Dr. Onuma was saying, was recommended, particularly for patients who would not present to the emergency room of our departments. For people coming from outside, we did recommend to have thrombolysis and shipped to us, and then we decide. Now, for those who present to our emergency department, we could not give them thrombolysis. We just brought them directly to the cath lab with the necessary protection that was available to us. Now, fortunately, we didn't have much STEMI patients in that particular period. So although we were a little bit afraid of having a COVID-19 patients in the middle of the night, where actually we don't have enough nurses to help you out and etc. We did have few of them. Now, what did help us actually being reassured is to have a CT scan systematically, even for the STEMI patients. So we sent them to the radiology department. They take a very quick look on their lungs and whether or not they might be a COVID positive patients, and then sent up to the cath lab. This I think was really very helpful. The test was not available, of course, all the time, and even if you make the test, then you will have to wait until the following day or maybe several hours in order to have the test. So the CT scan was very much helpful. So this is for the acute care, the acute coronary syndrome patients particularly. Now, regarding the outpatient clinic, it was shut down, completely shut down for 2-3 months at least. And we have contacted all the patients to send their parents to have the prescription refilled. So patients would not come back. They send one of their family members and they can get just the refill coming back to the hospital. Now, regarding the cancer patients, for example, I don't have really very accurate information about that. But what I can tell you is the most severe patients, they did not change any kind of their care. I mean, they need IV chemotherapy, they did have it. This is what I heard from my friends. And of course, for those who don't need that urgently, of course, they can wait for 1 or 2 months later. But those who needed that chemotherapy, I think they did have it during that critical period of time.
Mohamed, I want to add
Habib,
I wanted to add something else that I don't know if this was a phenomenon that you guys saw in Tunisia or in Egypt, but I know in Nigeria, there certainly was a lot of hesitation from the side of the hospitals and, healthcare facilities, and a lot of reports of hospitals turning patients away, who came in with, acute issues. Like there was one story, I mean, a lot of this is anecdotal, but, hospitals and healthcare workers being so afraid of COVID that they actually would not take patients at all. And I think there's some reports too from India, patients who had any sort of symptomatology of COVID, of which acute cardiovascular complaints, whether an ACS or decompensated heart failure, can have symptoms that are overlapping with what might be COVID. So I think this was one of the more kind of disturbing trends is, that of patients sort of being even turned away. You may have COVID, we can't even treat you, in this facility.
Yes, at the beginning, this is happening. This is what happened in the beginning because we don't know what's COVID, how to manage, how to deal with. Yes, we are in different countries. We go look to the media. Everybody is afraid about this, as if you are have, for example, AIDS. It's not just a virus, but actually, with the media campaign, with the training, with the infection control, the quality department, we have for the doctors, for the nurses, for the consultants. We train them, and then we have a triage, and we have everybody was afraid because of the deficiency and the PPE, because and how to wear the PPE is important because it wasn't clear at the beginning. Was doffing how to wear 2 masks, the gloves, the face shield, the distance. So when they are trained, they are now not afraid. They can manage. And even the director of the hospitals doesn't want to have these COVID patients inside. And our government, they have these patients in their hospital, not in the private or in university. But after that, they share with the private, they share with the, so that now it's more or less national or popular. So the fear disappeared or decreased. So, and the way how to manage is improved. That's why now it is, we have to live with the COVID in a normal life, new after COVID, okay? This is what Habib, can you add to this?
Yes, yeah, I mean, I completely agree with what you said. I just would like to go back to what Oyere was saying regarding turning down patients with I'm sure it might have happened in many countries in Africa and maybe outside of Africa. But now, regarding Tunisia particularly, it's very difficult to turn down a patient nowadays in Tunisia. Everybody is watching each other. So, and because of the wide use of the social media tools nowadays, I mean, if anything wrong happens, everybody will know about it the following day. And, you know, just remember one thing. One patient who was suspected of having COVID-19, there was an issue of finding a bed for the patient in the middle of the night. So they were calling the head of the ICU, and he was not responding to the phone. And what happened is the administration of the hospital, they called the Minister of Health the following day, and they have a complaint against that head of department. So at that particular period, everyone is watching, everybody is watching each other. And, you know, turning down a patient might be very, very difficult, at least in Tunisia. I don't know what happened in Egypt and other countries. But I'm sure it might have happened because there was people, they were really stressed managing these patients and seeing them, and they want to stay away from them, etc.
Habib, regarding your point about the CT in STEMI,
Yes.
actually there's a claim of in even Egypt, some of the Egyptian doing a consensus about doing a CT and then send patient the cath lab. So what's the importance of the CT? As if already your patient, you have to do it in 90 minutes to do the primary. So in my university and even in the private, we do the patient and as if any patient should be treated as if it is a COVID. But for those who are suspected PUI, we send them to CT. If it's positive, to put it in isolation because you don't have time for these kind of patients. For low risk patients, yes, you have to do it. Even high risk non-STEMI, you can do it because already it's not an emergency due to the 90 minutes. So I disagree about only the STEMI. Non-STEMI, I agree. Low risk, I agree. But regarding the STEMI, I don't have time at midnight to open the CT to spend 2 hours, 3 hours doing CT and looking for radiology and then come back. And then you have to do the aspiration or doing primary PCR and then do it. So what's your opinion about in practice after this?
You know, Mohamed, this depends from one institution to another. There was a protocol actually that we have signed with our radiology colleagues and telling them that we would need their help at any time. And by the way, in my institution, radiology department is just located next to the emergency room and that's downstairs. So they go from the emergency room to the radiology department. It takes only a few minutes, and then they go up to the cath lab. So they would not lose much.
No, sorry, Habib, it's not like this. I mean, if you find a no. I mean, COVID or non-COVID, do you have 2 cath lab in each part?
No.
In each department? So already you have. So it's the best is to treat any patient as if it is a COVID in the cath lab. I mean, we have to make 2 masks. You have face shield, gloves, donning all the feeds. Don't do any procedure except outside the cath lab if it is like a temporary pacemakers or intratracheal intubation outside, and then go to do what job and come back to the patient doing the CT, and after that, if it's COVID, isolate it. But don't spend time for looking just a COVID or not, because already you have a cath lab. This can be done if you have 2 cath labs if you have a COVID, send it the COVID cath lab, and this is not COVID, non-COVID cath lab. This is my opinion, but I don't know if it's right or not. But in practice, I do this. I don't look to, but regarding for the questions again, which we have to finish. If you have a complex patients, the question that a complex patients, and this complex patient and severe disease, either, for example, if you have patient with severe aortic stenosis, symptomatic patients, valve area 1 patient, are you postponed from TAVI or doing TAVI for this patient? If you have a patient, for example, with pacemaker is pacemaker. If you have a patient with paroxysmal atrial fibrillation tract, are you going to do ablation for this patient, or just what are the procedures which are being to be postponed in your department, apart from that you do primary PCI? Forget about streptokinase or Professor Onuma, what are the procedures postponed in your lab?
So again, I would say, all of it has been very dependent on what stage of the pandemic where we're in. So now sort of, we're squarely in what I would call the post-pandemic, world. We essentially are doing pretty much all of these procedures, and keeping in mind that here in the US, we do have access to rapid COVID testing, that we can use for these patients. So I would say now in sort of the post-pandemic era, we don't have so many delays in terms of what procedures that we are doing for patients. Now, if you are COVID positive and, this is not, you've had aortic stenosis, it's not emergent, we're probably going to give you time to get past the COVID infection itself and test negative before moving on, to any procedures. Obviously, like I said earlier, if patient's critical and they're COVID positive, we're going to be doing the procedure, irregardless. But in the sort of, not completely emergent procedures in which we have some time, for COVID positive patients, we're definitely, delaying until they come past the COVID infection, they test negative, and then, we can move ahead with, valve interventions or, pacemakers or AFib ablations or, whatever other procedures that we have on deck. But that is only because we're now squarely in that post-pandemic era. Things were very different when we were in the middle of our spike in, March, April.
I heard from Habib asked me before in his webinar of the Middle East, asked one of my colleagues in Jordan. He said me that if these kind of patients was sent for surgery, for valve surgery, because the reimbursement was so difficult in the pandemic era because it's very expensive. Although it is so they shifted. Although it's difficult to do aortic valve surgery, but they send it for surgery. Otherwise, the patient go for the medical treatment. Habib, regarding the coronary surgery and the valve surgery in Tunisia, how long they stayed and when they start these procedures, not intervention, I mean the surgery. Have the surgery continue with the stopped?
Yeah. Okay. In the first part of this pandemic, during the first wave, so the surgical colleagues, they almost stopped working. So because most of their work actually is an elective one, so elective procedures, and since we have stopped doing any elective procedure by intervention or by surgery, they have almost stopped working. And now, starting May and end of May and June and July, etc., they are back to work. And now they are taking the precautions that every one of us is taking, but they are back to work and they work just normally. They're just, they're doing their job, but I don't think what they're doing now is any different from what they used to do before the beginning of the pandemic.
Habib, quick question for you. Are you guys testing everybody, sort of, have the capacity to test pre-procedure, pre-surgery?
No, we don't have that. We don't receive a luxurious part of the antibody test for everybody. I know this is the United States and Europe is doing routinely for all those over cath lab, even in the ECC, these are the guidelines, but we don't have this facility for every patient. As I said, if the patient not primary PCR, STEMI, we wait for the patient triage, doing CT scan or the lab, and you can do PCR for these patients and wait in the triage area for isolation. If it is negative, and then we can continue for this patient. If it is positive, either to make it if it's an emergency, transferred into emergency, we do it in a COVID era. I mean that we have to take care of this COVID and be isolated with the patient. If the patient chip case, if the patient is non-STEMI, high risk, non-STEMI patient, cardiogenic shock or something like that. But if the patient have CTOs or TAVI or epithetic closures or devices or ablation, we stop, postpone till the patient recovers from this. Well, Habib, are you doing this in your country, in Tunisia? Antibody test for every patient or CT like us?
No. We're not doing
Habib?
that for patient. Yeah. Hamad, we're doing the same way than you. So we do it in case of suspicion and high suspicion, or if the patient comes from an area where actually there is a high prevalence of coronavirus, something like that. This is regarding what we do in our hospital. Now, I don't know if the question of Oyere is regarding testing outside of the hospital, the general population. What are the criteria for testing the general population? This is a different story because actually, again, people who are tested outside of the hospital are those who have symptoms or who have been in contact with contaminated individuals, or those who are coming outside from outside the country, because all of them, they need to be tested.
No. Regarding outside is another story. Yes, everybody now is easy to be diagnosed, and then they do by himself. Even in the private part, it's forbidden before. It should be to the government nowadays. I know a wedding last week in Alexandria here in North Coast with the youth, about 200 or 250, ending with 40 COVID. But test symptoms, I say home isolation. So because everybody knows that COVID is finished, but it's not finished. We are living. But regarding the hospital, we don't have the luxurious part to do antibody tests. But I said to you, when a patient coming to the hospital, triage, symptoms, the fever, chest, if he's suspicious, doing in the triage or the lab, body dimer, CBP, ferritin, CRP, and so consult chest physician, and then if the patient is the cardiac and a very high risk patient, about high risk non-STEMI or primary PCI, we do this. We don't do CT scan, but if there's no primary PCI, we do CT scan for every patient to confirm and then to manage. If this COVID and they have to be admitted to hospital, should be isolated. So finally, but now the answer from me and Habib and you, that we're coming back to elective cases gradually, not 100%, more than 75%. We are using now, I'm doing CTOs, I'm doing chronic coronary syndrome usual case. Now come to the questions of telemedicine.
May I ask you just a question? I think it's quite important.
Okay. Right.
Do you think there is the triage was really helpful? In our experience, I mean, we have triage everywhere. Before you go into private or a public institution, they measure the temperature, and that's it. And the people they go on. They go in now, when you know that more than 90% of the contaminated individuals, they're asymptomatic. I mean, what's the benefit of having a triage? I mean, what's the impact on that? So this is just. I don't know. What's your thoughts about that?
Yeah, triage for symptomatic cardiac patients. I'm not seeing triage for every patient in the street. Patient coming to the cardiac hospital because of cardiac symptoms. So you look the fever and then discuss about if there is still cough, any possibility of chest infection or dyspnea or just some patient after suspicions, PUR, patient under suspicions. You should triage them. Take your time for this patient. ECG is normal. Look for echo. Doing CBC. If you are in doubt, do more investigation, and then this is what's called triage, but not doing the test now. I'm just on suspicious, isolate the patient. But if there is no fever, if there is no cough, if no chest infections, and coming with severe chest pain, so why not triage? So go into the emergency department, and then treat as if it is the direction to the clinical pathway or acute chronic pathway in the CCU, ICU. But I'm speaking about those are fever, dyspnea, cough, patient coming from traveling, and patient in suspicious of now they ask for the fever, something or dyspnea. They ask about the test, the smelling, something like that, which is unusual. So there's 6 symptoms. Everybody now there is know that of the 6 symptoms of COVID. So they ask we have from the governments and also from our hospital checklists for those patients coming to the hospital. 1, 2, 3, 4, 5. If 6, if it is it's not unsuspicious, not going for triage. This is by law, you know.
Yeah.
This is by law. Coming to the hospital, every hospital in Egypt now.
I think that, you know, from our experience, and this is sort of speaking from the US experience, we're doing the same kind of triage, especially in the outpatient clinics, where you come in, you get a temperature measured, you know, you get a series of questions, you know, there's universal masking, and, you know, before you're even allowed into the outpatient clinics. Now, like I mentioned earlier, in the inpatient setting, we have more capacity, and we're doing, you know, a 100% testing, antigen testing for all patients in the inpatient. So if your test isn't back, you will be in the person under investigation, you know, units until we get either a negative test in which you can move on to the regular floors, or a positive test, then you go onto the COVID floors. But this is again in a situation where we have, you know, significant resources, you know, that allow us to do that. But in the outpatient setting, there's not the universal, you know, ability to test. And so we're relying mostly on, you know, triage questions as well as temperature checks in that setting.
Okay, Habib and Amni, regarding the telemedicine, I spoke to different webinars in Egypt and outside Egypt about the telemedicine. You know, it's new for us in our region. This what kind of telemedicine, because some procedures and diagnostics cannot be given or demonstrated virtually by healthcare providers. What alternative regarding the blood pressure measurements? For example, you can make it to home blood pressure, but otherwise, something is difficult. So, what alternative are you observing or looking to conduct routine screening and checkup in a remote base, and have they been effective? Are you believing in virtual visits and telemedicine in our region in the next year? Because already we are looking at some patients who are not going to the clinic, not to the hospital, on basis that not in. Start by Habib.
You know, Mohamed, in Tunisia and in our region, there was no telemedicine consultation. I mean, it has not been tested, it has not been done. Maybe because the period of the pandemic did not last much. I mean, the severe period where actually everybody's afraid to come to the hospital, there's only maybe 6 to 8 weeks. But it's being tested now in the US, in Europe. It's maybe useful. I personally cannot say anything. You know, our population is not well educated to be able actually to have this kind of consultation. You need to have internet connection everywhere. You have to have educated people in order to answer the questions very precisely. And so I really cannot, I mean, I just cannot say this is going to be the future for our region nowadays, at least. Now, telemedicine has been very, very useful in our region for the organization of webinars and education, for education of physicians and information about the COVID-19 and how to manage patients in remote areas. We used to do several meetings, you know, Ahmed. everywhere. Now we stopped doing meetings for the last 6 months or so, and webinars is absolutely great experience for sharing, for information, education, exchange of ideas, thoughts, etc. But telemedicine consultation, I have not tested. We have not tested here. But if the pandemic will last and things will go worse, we have to explore that in the future.
Onuma, Dr.
Yeah,
Oyere Onuma. Yeah.
So our experience with telemedicine has been completely different from what you're describing, Habib. And I actually think, this is, if there's anything that's been a little bit of a silver lining, in this pandemic has been, the ability to pivot to telemedicine. So here in the US, at least from, my institution, we did an almost 100% pivot to telemedicine in March. So initially our rates were about 3%. And, by mid-April, we'd gone up to about 90% of telemedicine visits. And it turns out that this is something that actually works well, not just for the healthcare providers, but actually for our patients, who have really, kind of adopted this telemedicine as well. The WHO, there's a recent WHO survey looking at, kind of the disruption in services in various countries. And they're actually reporting a 42% uptake in telemedicine, even in low and middle income countries. And I know the experience in Nigeria may not be identical to the experience we've had here in the US, but, people are using things like WhatsApp for, consultations now. It's not a, secure link by any means, but it does provide that connection from providers, to patients, and a way in which you can manage patients with chronic disease. Now, Mohamed, as mentioned, having telemedicine is not the whole story. I cannot check your blood pressure over the phone, or by video. So in addition to, our telemedicine capabilities, we've had to lean a lot into remote patient monitoring. So trying to figure out ways in which we can get, patient data like blood pressures, heart rates, and, other such weights and other such information remotely. So I think that this has been something that, has been kind of a really welcome, part of this, is that ability to pivot, but understanding that in the context of, the African context and in sub-Saharan Africa, the infrastructure may not be there completely, to support telemedicine to the extent that can fill in the gaps. But we've really leaned on it here in the US. And even now that things are better, we're actually thinking that we're not going to go back to 100% office visits, but we'll probably stay at about 30 to 50% of remote patient visits, even sort of in the post-COVID era.
Oyere, can you tell us how that consultation, happen? How does it how you do? Is it just a question Q&A session with the patient? How is it? How you can conduct a telemedicine consultation?
I mean, the thing that I miss the most, or what you miss the most in the telemedicine consultation, obviously, is the, part where you're physically examining the patient, specifically the, listening to a patient's heart or their lungs, or, looking at their, jugular venous pressure. I'm able to do a few things. Like I can say, look for low extremity edema. I can say, show me your legs, press against your ankle. So there are a few things that you can do. And, you go back to the basics in medicine. You're very much dependent on the patient's history. How are you doing? Are you walking? When you exercise, what? And then our patients, sometimes wear heart monitors like, Fitbit or an Apple Watch. So you start becoming very inventive in terms of, where you're getting the information from. But that's why I'm saying, the televisits alone won't do it all. You need that as well as some form of remote patient monitoring. And then in the critical patients, we're still bringing in, a select few for inpatient visits. But if it's your, chronic coronary heart disease patient, who has no new acute symptoms, I think a telemedicine or video visit works well as opposed to not having any contact with that patient?
I will start to say before the pandemic, the COVID pandemic, the relationship between the doctor and the patient coming mainly in the clinics, in the hospitals, and sometimes the patient in my country, not in. I was in the United States. It's very difficult to speak to your doctor, even in Europe. But in our region, we are so friendly with our patients. They can go directly to you by your mobile phone, send you the lab in the WhatsApp, and they need your connect. And sometimes they give a picture of the edema and send it to you. If there's something wrong, they send it to you. This is what happening before the COVID. After COVID, more phone calls, more WhatsApps, more FaceTime with the patients. But the problem, as Habib said, number one, in our region, we don't have, I'm sorry to say, governmental or database of the patients.
Yeah.
The collection, if you have a de novo patient, and if you see a patient, you don't have his records, how to see his records. If he's a de novo patient, you have to see him before deciding the decision. So it's very difficult to start with. Number 4, the culture of the patient. Number 5, the internet connection. Although it's good for some countries about the internet because they're really using Facebook. But I think some companies now are starting to make this a reimbursement of the doctor. The timing, the doctor is not speaking any time. He can speak, for example, and reimbursed through this company. These 2 or 3 companies in Egypt doing this now. But it's not so easy in acute. Acute cases should be in the hospital. For example, if you have a chronic heart failure patient and the patient is taking statins, for example, you have a lipid profile, they send you the lab and you speak to him. It's easy. The home blood pressure is easy. The Apple Watch is easy. This could be part of the patient. But how many of these patients are eligible for virtual visits? I don't think it's not more than 30% of the patients. This other 70 or 60%, you should see the patient because sometimes you have to listen, you have to examine him, or is a new patients, or this patient going for emergency. So 60, 70% going to the hospital, the clinic, and third. So the aim of the telemedicine is the decreasing the number going to the clinic, but not face to face. I think this is to be not to transfer everything into face to face. So what do you think, Habib?
Yeah, again, I don't know if that's applicable to our continent again. Now, there are one of the ways that has worked with few patients is rather to have the family physician going to the patient home, examine the patient, and then gives you a picture of what's happening with all those details, and then take a decision together. Regarding the change of medication or anything of that sort. And that's maybe less risky for the patient, particularly a chronic patient with heart failure or something like that, to go to the hospital, to wait in the waiting room, and to see the doctor, etc. And even an EKG can be done at home, actually, by the family physician and transmitted to the cardiologist. So this is one of the ways that is quite practical. It has happened in many of our patients for severe ones, but for the majority, again, it was not needed. At least in Tunisia, they just waited for the following appointment 2 or 3 months after that severe part of the pandemic. Now, for the future, we'll see again. Nowadays, people they're used to the virus, and they don't see any need to to have that kind of consultation. But again, this depends from one country to another, and we'll see what would happen. Now, a question, Oyere, can you charge the patient in the US for having a telemedicine consultation?
Yeah, so something else that happened is that the rules were changed, right? So the rules were changed so that the telehealth visits were reimbursed to the same level as our office visits. And this is not just from the provider standpoint. A lot of our patients really were not comfortable with coming into the hospital. And some still remain, uncomfortable with, the idea of exposures in a healthcare setting. So that's something that did drive it. Of course, a lot of things are driven by reimbursement, but the rules were temporarily changed to be able to reimburse, either the telephone or the video visits. But, an additional complication for us is, with the protection of, healthcare information, which is a really big thing, in these parts. You just can't, talk to a patient over WhatsApp or, any other unsecured, communication. So it has to be through our electronic sort of health record platforms, which is, again, an advantage that we have. But I have to say, overall, I think that there might be a really good space for telemedicine, even in sort of low and middle income settings and beyond, even when we come beyond COVID, as a way of being able to extend the care that, we can provide. The patient doesn't have to travel, an hour to your office. They don't have to take the time off work or off school or off what they're doing. And it just makes that, reach a little bit easier, and the cost of doing that a little bit easier is at least what we're finding. So I think that in future, there might be a way of pushing this even beyond COVID to be able to extend the services that we're able to provide to patients.
But I think the difference between the United States and the other areas is electronic health records.
Yeah.
If you have electronic health records, you are going to succeed, and the patient is convinced about you, and he's going. The second that most of the patients in the United States are not charging from their pockets. They are belonging to the insurer.
Yeah,
this is true. So it's not like those working in companies in Egypt. We are in a country, we have 70% government and 25% private, and 5 to 10%, for example, belonging to companies or private companies. And these private companies, okay, it's allowed for them that they are charging the doctor reimbursed from this company. But regarding the government, it will be so difficult in my country until there is an electronic health records or governmental electronic health records. So I don't think this is our time. But as I said before, at least for those on private business, 20-30% we can make it for electronic, and the doctor will be ready to make it on reimbursement, and the patient will be ready if he's cultured and he's trained to use his internet for this, and he's not in an acute situation. Okay, then let's go for another point. Regarding the pandemic, has introduced a whole host of stressors in our well-beings. Reduction in healthcare services are only compounded by financial strains. You know that reduced salaries are a financial problem, economic burden. There's a physical and psychological consequence of more sedentary life, because already you are at home, you are working from home, solitary lifestyle. Both of you, could you speak about any some of the bigger picture issues outside the control of the individual clinician or health system that are eroding health outcome and need to be greater priority for policy and public health experts for this kind? I mean, be in a solitary lifestyle, sedentary, financial traits. Starting by Habib.
Yes, I mean, I think the
Situation in Tunis regarding the salary, what happening from the pandemic era in Tunis, and what's now? What situation now regarding the number, the salary,
yeah, I mean the salary, the companies, particularly the rich ones, they have committed actually to pay their employees for, I would say, at least 2 months, which was March and maybe mid-March to mid-May. And after that, they went into very difficult situations, and then they have to fire many of their employees. So it's very difficult economically. I mean, and I assume it's the case of many countries. Tunisia is living a very difficult situation now, and many of the young now they're trying to flee the country to go to Europe, and you have maybe seen the Minister of Interior Affairs and Foreign Affairs, the Italian ones. They came to Tunisia last week just to explore this issue, because many of the young generation, they're trying to flee the country because of the difficult situation. I mean, it's not only COVID. It's COVID and other factors, but COVID has certainly made the economical situation very difficult and even worse.
Okay. Onuma?
Yeah, I think, for me, this is also one of those areas that I think there's a lot to explore and unpack. From the, standpoint of the COVID patients, there's still a significant, in some areas, stigma attached to that diagnosis of having COVID. And I think this weighs very significantly on the patients, on their families, in addition to dealing with just the physical burden and stress of the disease itself. So there's, widespread misinformation. People are already kind of at breaking point. A place like, Nigeria, a significant percentage of the population is already at poverty level or below. Then you add an additional stressor. And I think that this essentially, takes a big psychosocial toll, on people, on patients, on their families, on the general population. We know that these additional sort of, psychosocial stresses, they worsen our risk factors for, cardiovascular disease and other, sort of adverse outcomes. You get depressed, there's more depression, there's more anxiety, more worse outcomes in that setting. So I think that there are a lot of steps that need to be taken from the standpoint of, governments and beyond, healthcare workers or the health system itself. One thing is being sure that there's comprehensive, kind of risk education, that people understand and acknowledge the ongoing psychosocial toll of the pandemic, as well as making the resources available so that individuals can obtain the help that they need to try to address some of these stresses.
So do you have a media campaign regarding these psychological problems, speaking in the TV, and if the president speak about the psychology, the economic burden, they reimburse them for decreasing in the salary, because some of the workers, not usual workers, they are working and taking their salary per day, regarding the charge or per week, manual workers. How this can be solved in the United States?
Well, I can't say that it has been solved in the United States. It's definitely sort of, an ongoing issue, but, there's more kind of, a social safety net here than there is in other places. Again, I use the example of Nigeria, since that's a context that I know, quite well, is that this has been absolutely devastating for a lot of people, on so many grounds. The government's tried to provide some palliatives, as they call them, some, small amounts of food or money for the people who are most worse off in the communities. But that doesn't go a long way towards addressing, the issues and disruptions that have been caused by COVID. So I think there's still a lot more to be done, not just in terms of providing, food or water or some amount of money, but really acknowledging that people are under significant amounts of stress, from all standpoints in the setting of what's been going on.
Habib, did you find any psychological problems for your patient coming to you in these COVID pandemics? And they speak about the psychosomatic symptoms. Because this impact that they are living in sedentary life or solitary lifestyle, they can go to work, they work at home. What happened in the psychology of Tunisian, or the nothing? Because I know that this COVID is not so pandemic in Tunis, but I think that at least for a while they stayed at home working online.
Generally, what you notice in Tunisian patients very recently is just a general depression, and the majority of people, but not much. It's not linked only to the COVID-19 pandemic, but also to the difficulties that the country is running through, a very economic situation. And in the past, when Tunisia and the surrounding countries, these poor people, small countries, when they go through difficult times like this time, most of the time they seek help and support from Europe and the United States for funding, extra funds, etc. But for this particular situation, where actually Europe and the United States are living through the same problem, then they're not having and they're not finding the same support and help. So this is explain the difficulties of the people, and this is an impact on the general mood of the population.
I think this happened in the first 3 months, March, April, May, and beginning of June, middle of June, the Minister of Health and the pre-ministers, these trying not to decrease the salary. They don't insisting in the companies to continue the same salary, and trying to make it in the media to make motivation of them to work online and with the restrictions. And then at the beginning of June, because of the insisting on in going back to normal, they tried this, but with precautions. And then gradually till now, it started by 25%, 50%, now approaching about 70-75%. But and in spite of this, there is some economic burden in some parts. So it's trying to make it not. They stop the taxes for the first 3 to 4 months. It's very important to stop the taxes because this is be decreasing the economic burden, and trying to ensure this also in the media, in different parts of the TV or the social media, encouraging the people to withstand this COVID.
Yeah.
I don't know what's about the second wave, as you said, but I hope that will not continue for a long time. Then come to the last questions. Many corners of the medical community are predicting a surge in patients with advanced chronic disease in the clinic, in the hospital, after months of patients being hesitant or reluctant going to seek advice or spending less time with actors. What are the health system in your country doing? Number 2, what should they are doing to prepare for this potential influx in critical ill patients? I mean, there is a surge now. All of us noted that there is a surge because already we opened. Do you think that you have a protocol or health system in your country done to prepare for this influx? Otherwise, you have impact on the healthcare itself, or on going back to the COVID. What strategy be done, Dr. Oyere? Dr. Oyere, do you have a surge in United States? There is a surge, or still stationary?
No, I think a surge only in that, the levels were so low at the height of COVID. We were at about 20%, 30% capacity. And these days, I think we're closer to, 90% to 100% pre-COVID capacity. I think the biggest thing really has been, the flexibility in terms of being flexible with, being able to convert units to COVID when we needed to. So we had a few of our cardiac floors converted to COVID floors. We had, a couple of ICUs converted to COVID ICUs. We had, doctors, cardiologists and, other specialists who were deployed to work on the COVID floors, when we had the surge. And really, I think a lot of it has been being flexible in that capacity. So now that the cardiovascular volumes are increasing, we've converted our floors back to cardiac floors. Cardiologists are now back to focusing on cardiac patients. And, we've sort of, rebuilt the capacity that we had before. But I wouldn't say that we've seen an excess of patients. I would say that we've just returned at what the volumes were sort of in pre-COVID era.
Yeah, I agree what Oyere was saying. I mean, we're saying seeing maybe a relative surge compared to the initial period of the pandemic, but we're back to the usual work. And in Tunisia, despite the difficulties in economy, we have a very an excellent healthcare system where actually 80% of the is insured. These 80%, they have the choice of having a public sector quality of care or a private one. The 20% remaining, they're completely taken care of by the public institutions. So for chronic disease patients, for particularly cardiovascular disease, there was no much concern. So I can tell you that the patient in Tunisia, when he has an acute MI in midnight, you go to the closest hospital, he will go to the cath lab immediately. We don't even look to his paperwork and what kind of insurance he has, which is absolutely, outstanding for an African country. I know it's not the case for the other African countries, but this is what happens. Now, regarding the pandemic particularly, and the care given to the COVID-19 patients, you know that we have private and public institutions. The private has not played the necessary role. And most of these patients, they were taken care of by the public institutions and surprisingly for free. So almost patients, they don't pay anything if they have COVID-19, which is again excellent in a country which is not very rich from Africa.
I agree completely. This is the same what happened in Egypt. The government was taking care of all COVID patients for a long time, and then when the number increased, they starting to make the private. Actually, unfortunately, the private paid a lot for the patient. But in spite of restrictions coming or instructions coming for the government, but it's still very expensive. But most of the rich people won't go to the private. But nowadays it's decreasing. We flatten the curve. I hope that will not be increasing anymore. But still in triage in different hospitals, we're coming to gradual return to work. But we have a lot of PPE, a lot of drive-through now. Drive-through, I mean the PCR in different parts of Egypt, not only the government itself, in the private and non-private, so everybody can do his own PCR. Is very, very easy. The media is still concentrating that we didn't kill COVID till now. We are waiting for the vaccine. I think this is the best answer. Wait for the vaccine. Maybe the vaccine starts in the United States. I don't know. We start in November or before November. I don't know. But I think if you finish, and please don't forget the African countries to send them a cheap price the vaccine. We are making deal with China. I don't know it's be correct or not, but please start doing in the pilot of this vaccine in our Egyptian population. The last question: ensuring patients receive the care they need is a community effort. What are the opportunities with community volunteers and support networks to keep one another positive and healthy right now in way that guard against the virus? Habib?
Yes. What I have to say, Mohamed, is during the initial part of the pandemic, civil society has played a major role. I can tell you. I mean, many people they made donations for PPE. They send it all over to hospitals. We have civil society coming to our hospital asking if we need anything. ICU beds, echo machines, anything they want. I mean, that was a very positive move in the community, and it was absolutely great. Now, once that's over, and and again in the second wave, we're not seeing anything of that, and sometimes we're seeing very bizarre things. I mean, you go to a wedding, for example, and they went to one of those last week with almost 1,000 people in the same room. Nobody was wearing a mask. So that's something that is frightening. So community volunteers, we have an excellent demonstration in the beginning because people, they were really afraid of the pandemic and the consequences. Now we're losing that fear, I would say, and enthusiasm to control and to be really protecting this virus.
Nima?
Yeah, I would say it was the same experience. In the beginning, we really, had community volunteers who came in to try to bridge, some of the gaps in care delivery that came in the wake of the pandemic. We had people in all sorts of efforts, making masks, bringing food for healthcare workers, even working within the communities, providing groceries, for elderly people and people at risk who couldn't leave their homes, or even as we're talking about telehealth, banding together to deliver devices to, elderly people, or helping them sort of figure out how to configure, their own devices. So I think that these efforts, have been helpful. It's critical for all of us to know that we're kind of in this together. It's not just, the healthcare workers and the hospitals, but also kind of, as you were saying, going also beyond, these community efforts into understanding the reason why we need to wear masks and, socially distance and do everything that we need to do as a community to bring, this COVID under control. So I would say that, it's a critical part of the response and should go, hand in hand with the efforts that we are being made on the healthcare side.
I feel that a lot of the Egyptian thinking that the COVID is finished, but this is not true because already it's close to us now. As Habib said, there is a wedding. Yes, a lot of weddings in Egypt now in the last months, but it's not in hotels because it's forbidden to be in a hotel now. It's closed. It should be short now. That's why a small number of that's why make it in open air without a mask. The young so we saw that they are not vulnerable to have COVID, but already they have COVID. I know it's mild, but already they have COVID. So as if it is a herd immunity. So they believe in this. So I think that next month will be so recycling of the same story again, and more masks and more concentration in the media. The Prime Minister made a warning last week about if this is increasing, I'll have a more restriction. So I think we will take care the next month. Regarding the volunteers, yes, they paid a lot in the beginning, but because already they think that it's no COVID anymore or less COVID, flattening the curve, they don't pay anything. They come back to normal life. So I'm afraid of this, but I hope that the government will deal of this punishment of this. I admire what's happening in Dubai. In Dubai, if you have we're not wearing a mask, they are making hotspots. They are looking for you by the cameras, and they make penalties for you. So it's very difficult. I think the best is to pay for your to make the penalty for your fault. This is the best attack. The second, not to make sure that there is COVID or non-COVID. If you pay from your pocket that you are full, so you're doing more. This is the best way to control it. I think we are going to kind of summarize what we said. We have two questions about the research. Actually, about we have some researchers in our regions and celebrities and clinical trials and the new drug approval waiting for the vaccines, epidemiology. We have 7 questions. We have still trials. Now we are working with a new life, making the acute emergencies, coming back to the elective cases. Telemedicine is questionable on our region. I know it's United States, but question, as Habib said, it needs time for us. But as I said before, it should be for 20% at least for our patients. Regarding the resources, I agree about what's happening in the United States. The JAC and the ECC said that they saw 3 levels of using resources, and this could be distributed according to the government. Some hospital for regular services, some hospital most services, some hospital for some services. And regarding the economic burden. I hope that the governments will pay for this economic burden and then come back. The psychology, depending on the media, on the doctors. Still, we have to use the PPE, and still we have in triage gradual return. We're looking for the avoiding second wave, looking for the volunteers to support the networks. Out of your days to join these important conversations. I hope our viewers will be on lookout at the third and final instrument of this regional discussion. Later this year, we'll have NCD Alliance will be moderating our final panel on how not to simply sustain standard services for NCD patients, but to act on more ambitious policy frameworks for closing long-standing gaps in the outcome worldwide. If anything, add from Habib and Habib, start by Habib. Anything you can add to what's happening and what's your advice for the next NCD Alliance meetings?
No, there is nothing really much to add, Mohamed. I think it was have this webinar and have this exchange about what's happening in Africa and also in the United States. Now, the final message is to be addressed to our population mainly. I mean, to be really careful, as you just mentioned several times. This pandemic is not over, and it's able to kill a lot. Although it's not really visible, we don't know exactly. It's killing everywhere now in the Americas, particularly, but it can come back with a very, very terrible surge later on with a high mortality among our population in Africa that is younger than in the rest of the world, and we can really pay the price very, very, very high.
Oyere?
Yes, I would echo the same thing. The pandemic is absolutely not over, and we should not think that it is. However, we can continue to learn as we go along, and we are learning and doing things a little bit differently as we have more knowledge and we have more information. I think for me, the final thing is just to say, we should also be looking for the opportunities, that will come through this pandemic to improve what we do in terms of our care for our acute patients with NCDs, as well as, kind of chronic long-term care. So what opportunities can we find to improve the care of our patients through this pandemic and beyond?
Fani, thank you very much, Habib Gamra, past president of the African Heart Network, president Tunisian Heart Foundation, head of cardiology department, Fatuma Bourguiba University. Thank you, Oyere Onuma, assistant professor of cardiology at University, former medical officer, cardiovascular management, World Health Organization. And I'd like to thank NCD Academy, particularly Bryson, for preparing this second webinar, and also David Lee for technical support. And hope to see you in this year for the third webinar with the NCD Alliance. Thank you very much, and have a nice weekend. Bye-bye.
Mohamed, thanks.
Thank you very much. Bye-bye.